So good afternoon, everyone, and thank you for joining us for the fourth session of the 2024 Older Adults and Opioids webinar series hosted by the Finger Lakes Geriatric Education Center. We are a HRSA-funded geriatric workforce enhancement program at the University of Rochester, and our co-sponsor, the Western New York Rural Area Health Education Center, is also a HRSA-funded education center. This year is the fifth year we have been hosting these educational sessions, and thank you so much for your support and for tuning in. My name is Laura Robinson, and I am the program coordinator for the Finger Lakes Geriatric Education Center. And my co-host is Christine Chappell, the administrative coordinator at the Western New York Rural Area Health Education Center. So just a couple housekeeping items before we begin. We are using Zoom meeting format today, and there are two important buttons on your toolbar. Mostly chat. First chat, type hello and introduce yourself with a name, job title, agency, and location. We have people from at least 13 states and 2 countries joining us today, possibly 3 countries. The chat button will also allow you to type in a question for the presenter. When we get to that later, we will leave time at the end for questions. And then also please keep your microphone muted throughout the presentation. And now I will go through our disclosure slides. So that is our speaker pictured there on the first slide. And today for this session, we are offering CME, social work, PT, OT, and licensed mental health practitioner credits. None of our speakers or planning committee have any financial disclosures or conflicts of interest. Following this session, we will email you instructions on how to claim credits. Please allow up to 30 days to receive your credits. I know some of you like to log into our CME and social work system right after the webinar. They won't be there yet. It takes me a little bit to go through attendance and then send them over to the CEL office, and then they upload them. So maybe at least give us a week, but up to 30 days. And no commercial funding was received to support this activity. And if you have not already registered for the next webinar in the series, please use this QR code right now on the screen to join us for Savannah and Benjamin next month, who will be talking about aging, the opioid epidemic, and care considerations for Native communities. So now I will stop sharing my slides and invite Dr. Holahan to share his slides while I introduce him.
All
So
right.
our featured speaker today is Dr. Timothy Holahan. He is an assistant professor of medicine at the University of Rochester Medical Center in Rochester, New York. He is a board certified geriatric medicine and palliative care physician. His current medical practice involves caring for complex patients in skilled nursing facilities. He is currently the medical director at 2 local nursing homes and medical director of the Monroe Community Hospital Ventilator Unit, and a geriatric hospitalist, medical director of complex transitions at Highland Hospital. And then in his spare time, he is also currently the vice chair of public policy for the American Medical Directors Association, or AMDA, and has served on multiple other state and national committees advocating for the care of older adults. So we're very honored to have such a dedicated and experienced long-term care practitioner with us today. So I will now turn the program over to Dr. Holahan.
Thank you, Laura. And I'm assuming, Laura, my slides are looking okay.
They look
Right?
perfect.
All right, great. So thank you for that introduction. And yeah, I just want to update to that. You mentioned my free time and spare time. I'm actually the chair of public policy for the American Medical Directors Association. That just happened last month. So I'm even busier than I was as vice chair. So, but I love all that stuff. I love, getting involved in policy at state and national level and advocating for our older adults. And partly why I like this topic so much, specifically medical marijuana and the older adult, that crosses different kind of areas of care and different, really goes from the hospital all the way down to the home in terms of impacts and how it's nuanced in each setting. And there's actually a lot of policy that goes behind, the journey of medical marijuana in this country and how it's used. So it's a really interesting topic clinically for me. And I hope you find it interesting too, but also from just, like I said, a political and policy perspective and other things and kind of where it stands. So, all right. So I'm just getting used to moving my slides there. All right. So I have no financial disclosures. And I apologize. I'm gonna look in the camera. I'm doing this two monitor thing. So if I glance over to the side sometimes, I apologize. But I have no financial disclosures, learning objectives, uh, understand the history of medical marijuana use. And it really, the point of that, I'm not expecting everyone to be an expert in this, but it's just interesting to kind of see where it started. It's actually one of the like oldest forms of medication that's been used actually in the modern world and even in ancient times. So it's been around forever. So it's really cool to kind of understand that history and where it comes from, and also kind of its journey through like being very commonly used to also being heavily regulated. Understand the pharmacology of medical marijuana. I won't get into too heavy with that, but I think it's important to know a little bit of the details. Describe the different formulations of medical marijuana and the conditions they're used to treat, and understand the current research regarding the use of medical marijuana in the older adult population. The other thing about this talk, I usually give it, maybe every 1 to 2 years, but it's always very different because it's constantly changing. Whether that's more research that we have in terms of its use, or in how it's changed in our country in terms of policy, regulation, where it's legal, where it's not legal. So it's, even though I kind of give this every once in a while, I always learn a chunk new whenever I give the update. So we're gonna get right into it. Uh, don't worry about that. Oh, hold on one second. Sorry. Fix that. There. So don't pay attention to that one slide that's up in the corner that's very chemistry related. You can if you want. If you want to really stare at that and study it, you can, but don't ask me any questions about it. But those are basically just the different structures of what makes up actually marijuana. So you have the THC component, which is a very different structure, and it has very different properties than the CBD component, the cannabidiol. So really, that's what kind of makes up marijuana itself. But then really what dictates treatment or how it impacts how you feel, or all these other kinds of things, the psychoactive effects really depends on the ratio of those two things. So I love this chart because it really talks about the differences between the two. So as you can see, you have the potential benefits and side effects, and they're very different for each of them, right? So CBD, I'll just start with that one, but it's non-psychoactive. It's actually neuroprotective in a way. It's an anticonvulsant, antioxidant. It has a lot of really good anti-inflammatory properties to it. It's actually an antipsychotic in a way. It's not. It doesn't have that psychoactive component to it. Um, and it's got minimal to no side effects. This is why you could buy pure CBD over the counter, right? So when you go to a health food store or somewhere else, at least, in this country and how it's been over the last, I'd say 10, 20 years, it's easily findable and used because there's not potential for abuse. There's not potential for other side effects risks. When you look at THC, this is the other part that has some benefits, but can also have some side effects. So you have the psychoactive component, relaxant. It's an appetite stimulant. This is where you get that appetite after effect from if you ever use medical marijuana. Analgesic, though, effect. This is where THC also, although CBD has an anti-inflammatory and some analgesic effect, THC also has an analgesic effect, so it could be additive. This is where you get your euphoria, your paranoia if you use too much, your anxiety as well. So it's really a fine dance, a dance between these two compounds and the type of impact or clinical benefits or risks you're going to get with them. So if it's one of those like big slides where you don't if you get only one or two things out of this talk, this is a really good slide to help you just orient you with the differences and how it's used. So a timeline of medical cannabis. So as you could see, as I said, it's been used forever. So there's even reports, even up to like 2000 BC, with ancient Egyptians used cannabis to treat inflammation, and there's some records of that. And even 1500 to 1000 BC, it's actually described in certain literature, and in 300 BC actually comes to modern day Europe, believe it or not. So even in that sense, it's been in Europe for a long time. 70, you have Greek physicians. classifying cannabis as a healing herb. So even then, people were saying, its positive impacts. Um, Eastern medicine and Chinese have used it for a long time as well as an anesthetic, believe it or not. And it actually, so then it kind of had its role, and then in the 1800s, it's when the West, in terms of United States and Canada and other countries over in this part of the world, really started embrace cannabis as medicine, and even in Europe as well. 1851, cannabis was actually added to the U.S. kind of pharmacy lexicon, how the drugs we use actually. So even in the 1850s, it was seen as a drug that could have positive impacts. However, as you get to see with the thumbs down, I kind of like 1937, cannabis was outlawed in the United States. And actually, people didn't also know how much it worked. So really only until the 1960s when was THC component discovered, and that's where you get this balance between THC and CBT. People didn't really understand marijuana or how it works until the mid 1960s and all the components. But then, and so then there was this period, this dry period of like, it was used obviously, um, uh, people really associated it with just drug use in general and other things. But then in 1990s, things changed. So in 1996, California was the first to legalize medical cannabis, and that's really progressed from there. In 2001, Canada actually legalized medical cannabis as well. And then, as most people I'm sure know, and I'll go through it a little bit more, is that it's really not just for medical purposes, but it's really increasing legalization for recreational use as well, especially over the last 10 or 15 years. So I just went through a lot of this, like I said, so I'm not going to go through it again. Um, but you know, federal restriction when that happened, and then also in 1970 with more stringent federal penalties and restricted use. Um, the problem with that is that it also led to decrease in research funding. So it was really hard for folks to learn more about it because it was not funded very well. So it's really hard to do research, right, when you don't have money. So that really was a negative of all this. But that's also been changing over the last 10 to 20 years, and more research is being done for us to actually learn exactly what is happening and what are the benefits and the risks of it in more detail. So that's very good. Um, so today, I'll just point you to the last sentence there. Um, 38 states, per my count, this really changes pretty often. But for my count, there's about 38 that have legalized medical marijuana, so a lot, a good chunk. About approximately 28 to 30 have actually legalized recreational as well. So it's really, really growing in that sense, and a lot of states have really been legalizing it in some fashion. So it's something to keep in mind. Some current use and statistics. So uh, really prevalence, I mean, this is not surprising, is really going up tremendously. A lot of people are even globally, right? When you look at the world's population are using cannabis of some form. This could be updated a little bit, but when you look at these numbers, 48 million people, just to give you a sense, in the US reported use of cannabis at least once in 2019, and that year per CDC. And of course, it's probably more now. Won't be shocked if that's more in the 55 to 60 million range if you looked at it now. And this is just another slide to give you a sense of where kind of set cannabis in general is going. As you could see, this projection, if you look at, I mean, this is in billions of dollars, right? So if you look at 2022, 2023, 30 billion, 35 billion, and in 2024, 39 um, to 40 billion. But when you project that out, I mean, really, when you look at about five years from now, um, it's almost double that in some um, projections. So it's not gonna go away. If anything, it's gonna be more, I think, and it's something I think we should all be familiar with if you work in healthcare, because it's just not going away, whether you agree with it or not, or totally appreciate the benefits or not, or feel like risks are worse than the benefits. Doesn't matter. I think we're gonna have to counsel our patients about it and also deal with it. So recreational marijuana legalization in New York State specifically. So I'm sure most people know. And I always like to look at this because even how many dispensaries are growing over the last 3 years is pretty incredible. So recreational marijuana is legal in New York State. There was actually, when this regulation came out, it authorized lawful use of adult use recreational cannabis and the lawful use of medical cannabis in 2021. It did take a little while for it to really pick up steam, especially like a year or two. But you're definitely seeing more things now. And these legal guidelines were very extensive. I mean, this is just one slide, but that's not the purpose of this talk. But it has a lot of guidelines about consumption, growing, the sale of it. So there's a lot in there. I will say I just looked at the number of retail dispensaries in New York State, and you can find that on the New York State website, Department of Health. So just to give you a sense, when about 3 years ago, when we first doing this, there was probably only maybe 30 or 40 at the most, and that has tripled. And I looked at just this a few days ago. So there's now 112 retail dispensaries in New York State, and I'm assuming we'll continue to see a little bit more. And as Laura mentioned, of course, I'm happy to take questions. It's hard for me to look at the chat as well. And yeah, I'll try to take some at the end for sure. So if you have any questions, just put it in the chat. So current federal position, and this is the last I'm kind of going to get into, well, at least for now, for a little bit about the regulation and the policy, and then we'll get into pharmacology and its uses, especially in older adults. So current federal position, there is some push for sure to actually legalize it at a federal level. And this is important because when you're also working as a geriatrician and taking care of older adults, whether when you're in a healthcare facility, whether it's in a hospital or nursing home, assisted living, this has very important implications because even though it's legal at a state level, it's not legal at a federal level. So it's really hard for folks, not just recreationally, but for medical use, use medical marijuana still in these facilities. It can be done. For sure, it has to be done though a certain way, and only a few facilities I'm aware of have really done true medical marijuana, at least that I know of in the nursing home. Again, it can be done, but it's hard to do. So it really kind of became challenging until that stance changed. It's still a Schedule I controlled substance federally, and there is some active bills still being worked on right now. But I still think, given the way kind of the current makeup of Congress, and also depends on what happens with the presidency and things, I still think true legalization might be a little ways away. Could they declassify it in terms of how it's prosecuted and how illegal it is? I'm sure that could possibly change, but I still think I think it will happen at some point, but I still think we're a little bit away. All right. So pharmacology. So what's really interesting about medical marijuana and just the cannabinoid system in your body, the endocannabinoid system, and how it responds to drug, it's actually been really rigorously studied. So if you actually go into pharmacy books and other things, it's a very understood mechanism in terms of how it can treat pain, how it works, some of the impacts it can have. Again, I'm not going to get into too much detail here, but receptors are mostly located in the brain and spinal cord. And really it involves the activation of two types of receptors. So again, one's in the brain. There's also a component of receptors that also locate in the immune system and can actually directly inhibit neurotransmitters such as dopamine, and it actually affects NMDA, opioid receptors as well. And this is where the pain control comes in. And this is really where you can see some of those anti-inflammatory benefits, some of those pain control benefits. So it really acts across many different areas of the body. It can have wide ranging effects. And remember, THC and CBD will work a little differently there. Oh, sorry. So there's two, actually, as I mentioned already, primary cannabinoids in marijuana. When you think of marijuana, it's THC and cannabidiol or CBD. And THC, as I mentioned, is the psychoactive effects. CBD or cannabidiol is the non-psychoactive, possibly even some anti-anxiety, possibly some antipsychotic effects. The other thing, though, that's really important to know is that there's actually a lot more also naturally occurring cannabinoids. It's kind of like that are normally occurring actually in our bodies, and actually how they're used to transmit anti-inflammatory and other messaging throughout our body. So we actually know a lot about marijuana and the components of that, and it's been studied. There's also a lot of other ones that occur in our body naturally, that we actually don't know all the effects of, and they're not well defined. It's not really clear how they all act. But I guess my point of the slides just show that really from a natural perspective in terms of how our body works, there's a lot of cannabidiol and cannabinoids in general that really are always ongoing in our body in terms of how our body works and communicates with other systems. So it's just something to be aware of. Um, this is another really important slide in terms of how it works. And this is something that I tell patients, um, and I really like to focus on this because this is also where you can get into trouble. All right. So onset of action is variable. So it's really different for everybody. You can really get immediate onset to a degree for some. And it is also very much impacted with when you ate last. Did you take it with food? Is it on empty stomach? All those kinds of things, and what other medications you're on. So it's hard to know exactly, and you have to be slow. So I always recommend people, so it can be as quick as 30 minutes, but as long as 2 to 3 hours. So say it's been an hour and you're looking for an anti-pain effect or anti-anxiety effect or something that hasn't happened, I would not take another one in an hour. You know, this is where people, because then 2 or 3 hours from there, you could be in some trouble and be getting side effects. And then the other thing is the duration of it. Not just the onset is variable, but the duration is as well. It's variable. It can be actually up to 48 hours, 4 to 8 hours. So it's hard to know how your body's going to react to that. And you have to really be careful with close repeat dosing. Renal dosing, you should use caution if some of, especially in our older folks that have some chronic kidney disease. Um, so another reason to start low and go slow, the geriatric medicine mantra, and it's not established. So until it is, I think especially even more caution if someone has some renal impairment. So current formulations, what's out there and how are they used? Currently, there's 3 FDA-approved cannabinoids. The most common formulations, I think this is important to know, is just what you're going to find, like what are your patients using and and how are they consuming it. So most common formulations of medical marijuana include inhaled, which is I think the way, smoking it, edibles, okay, tinctures, which is small liquid um, amounts, basically, forms of it, sublingual sprays, topical. There's a lot of different ways that people consume it. And the reason why that's important is it's actually going to impact its onset of action, duration of action. So it's very important to understand what they're actually using, not that just they're using it, but how are they using it. And the other big thing to understand is ratios of THC to cannabis to CBD matter. So a lot of these, even if it's inhaled, edible, liquid, it doesn't matter. When you hear something like that, the next question should be is what is the ratio of what you're using? Because, and I have a great slide for this that'll show a little bit what that means. And THC and CBD work together. CBD can actually lessen or even out the effect of THC. So it's actually good to have them both together. If you just took pure THC without CBD, you would be pretty crazy pretty quick. So it's very important that they're together. So this is just an example of some of the ratios I was talking about, and this is like a tincture, in the sense of one way to consume it, which is in a liquid way. You can either do it sublingual or put it on your tongue. As you can see, the ratios, it's hard to read, I know, but can really vary 3 to 1, 1 to 1, so an exact even, or a huge range difference of 20 to 1. This is a great slide, and I think folks will find this, I hope, um, pretty meaningful. This really goes through the effects and the differences when you look at the ratios. And as you can see at the bottom, you have less CBD. And as you go higher, you have high amounts of CBD and low THC. So you can see how the effects change. And the amount that's right for you is really different. And this is where I think when we're talking about our patients, they have to be careful with this. So as you can see at the bottom, there's a 1-to-1 equal ratio of both of them. And this is if people who've never used it before, who are beginners, you got to be careful with this. There's a good amount more THC in there. And then as you go up, you get more CBD. and not as much THC. So like when you look at the 5-to-1 ratio, this is considered mild range and best for those who have some tolerance to THC. Still might want to try the dose at bedtime, right? Just in case, but that's going to be a little more well tolerated. 10-to-1 is kind of a good sweet spot to try, or even 20-to-1, where people have never had it before. It's not going to cause much impairment in terms of psychoactive component, and it's very rarely intoxicating, but you're still going to get some inflammatory impacts, but just a little THC to help maybe with a little anti-anxiety, a little more pain control. And some of these also you may want to take more during the day versus at night. Um, and then you can go all the way up, really just pure CBD is at the top, and that's all anti-inflammatory, a little bit effect, but you're not going to get any THC components, so you're not going to get any of those other benefits from the THC. So, the good, the bad, and the ugly. So there's a lot of interesting press about medical marijuana and how it's used. And I really like to go through some of the studies for folks in the sense of what's the most recent research, what's the most recent data, because there's definitely positives there are definitely negatives, and I think it's important to continue to understand this and review it as we learn more. Um, I hope people know who that is, Clint Eastwood. I hope many people still know who that is in that movie. I'm kind of an old movie buff, so I can appreciate that. But these are just some other articles that have come out in the last 6 months, about older adults using marijuana, mostly for pain, and anxiety and other things. But as you could see, this is the New York Times, the top one's Washington Post. These are widely read articles, and I think really shed some light. If you want to check them out, go for it for sure. But it talks a little bit about why people are using it and why there's such an increase, but also some of the risks that can be associated with that is too. But people are using it. People are going for it, especially older adults. So it's important we keep an eye on, as I said. So common indications, what are people using it for? So this was a really good article that came out in JAMA in 2015, so relatively recently. And it was about, for medical use, a review of all the data of what people are using it for. And it really kind of went through like, where's the evidence? What at least conditions show maybe a little more benefit than others? So there was moderate quality evidence to suggest benefit in chronic neuropathic pain. Here we're starting to get into more of our pain regimen in terms of what it's used for. Cancer pain for sure, multiple sclerosis, and maybe some spasticity related to that. There's some evidence to support its use in nausea, vomiting, as well, due to chemotherapy and kind of failure to thrive and sleep disorders. But there's also right at this point no significant data to support its use in dementia. This was a hope, to be honest. I'm not saying it's over and done, but maybe there's some actual data here that could show its use in dementia with behaviors as well, and actually be safe enough to be used. But it's really not well studied yet, and I'd say the jury's still out on that for sure. So then we come to what are the approved conditions for medical marijuana in New York State. So every state kind of does this to a degree, and it's really based on which conditions is the risk benefit ratio appropriate, where at least from a regulatory perspective, people feel comfortable using it and allowing people you know, providers to prescribe it for. So really the indications are the problem. So with this is actually it's wide ranging and some are quite vague. So you could end up seeing people using it for sort of reasons that are a little bit kind of, I don't say wishy-washy, but it's kind of hard to know what they're being used for. But things like ALS, cancer for sure, seizures, there's some good data in seizures as well. Help with that. HIV, multiple sclerosis, Parkinson's disease is another one there's some good data for. Where they get into the pain part, it's chronic pain. So pain that lasts 3 months or more, that's all they say. It can be used for chronic pain. They don't say for specific types of pain. They don't really get into the detail there, but just if pain has been going on for 3 months or more, that's an approved condition. The other big one that's really interesting here, and it really overlaps with our pain control, is opioid use or substance use disorder. There is some data that medical marijuana it's used for in patients with chronic pain can be opioid sparing. So in folks, especially with the opioid epidemic and people using a lot more opioids and having issues related to that, there is some interest that maybe medical marijuana can still treat some pain, but also allow people to back off on opioid use. There's positives and negatives to that, but there's some data that supports that. Um, the other indication in there that's really interesting, I think, is pain that degrades health and functional capability. That's very vague, right? Like I feel like all pain does that. So I think if you can make that argument per at least in your state and how it's structured, you could actually say that's a approved condition for medical marijuana. So really, you could use it for a lot of different things in our state. So medical marijuana in older adults specifically. So there's been a little bit of studies on this, not a lot. There actually, and I'll get into these in a few slides, but there's actually more recently that's been done. This was one came out in 2018, so it's a little bit dated, but basically they received, they looked at greater than 65 years of age, older folks in Israel actually, and they received medical cannabis 2015, 2017. The data was actually really good. The mean age was 75. The most common indications were pain and cancer. I'm assuming also cancer-related pain. But after 6 months of treatment, pain score was much better. 93% reported improvement. And the big one was 18% stopped using opioids or reduced the dose. This is where I think there's some of that interest where medical marijuana can be used to supplement pain control and other things with opioids while also getting folks to actually be able to wean down off the opioids over time. So that's where a little bit some of that interest came from. So what are some of the side effects we see, especially in older adults that are using medical marijuana? So there's a few for sure, and some of them can be concerning, especially in older adults when we're talking about fall risk and other things. But the most common side effects to be aware of are dizziness, okay, which makes sense, dry mouth, fatigue, confusion, some as well. So there is that. I see, it doesn't have to be that. I wouldn't say that these are common, in the sense of like they happen obviously to everybody, but you do see some folks that will get this. There's also a questionable increased fall risk, although the evidence supporting this is limited. So it's very questionable if it increases fall risk. But as you can imagine, if you're seeing some of these side effects like dizziness, that could increase fall risk, right? So I think you have to be careful with how you're using it. And it's also another reason to start at low doses because you just don't know, especially in older adults, as their metabolism changes and how they interact with other drugs and they take more medications. You have to start slower, else you could have more side effects for sure. And again, where to use caution. Um, in chronic kidney disease, decreased urine output, their inability to clear the drug. I'd be careful in those patients. Liver disease. Again, patients, if they're already having frequent falls, I would be very careful with that because, sure, if they're already having falls and you had a little bit of dizziness, that could make things worse. Patients with a lot of different medications, that could be concerning because how is it interacting with all of them? Another patient to kind of be, an older adult to be wary of its use. So again, this just sheds a little more light on that kind of medical marijuana is opioid sparing. Again, I think it's possible it can be, and there's probably some data that supports that. How much, I still think we're not sure, and we have to see where all this goes. Um, this is interesting. And this was a study that came out in the Journal of Psychopharmacology in 2017, and um, they looked at actually what people substituted medical cannabis for. So they substituted for pain, and how did that go, or anxiety or sleep? Um, and they also reported this decrease. So three-quarters of opioid users reported decreased use after starting medical marijuana, decreased use of opioids. Um, 71% reduced their use of anti-anxiety medications, so things like Xanax and other things which aren't good. So that's encouraging. Um, and 66% reduced their use of medications for migraines. 65% reduction in medication use for sleep. So it can actually be somewhat, for this study, and maybe this is possible, does it have wide-ranging impact? So if you're just prescribing it for pain, but then it also has an impact on improving sleep or headaches or other things, you can actually get rid of a couple more medications as well if it works for them and it's safe for them. So there's some encouraging data for that. And this is kind of what gets to that medical marijuana kind of decreasing polypharmacy, right? So it's kind of, what's the going to cause the least harm, so to speak, in terms of a medication. And this is just kind of there was another study that came out in a pain journal as well in 2017 that they looked at 2,700 people and 46% reported substituting cannabis for a prescription drug. And actually it was 2 drug substitutions for each respondent, which is pretty good. That means that they took that and they got rid of 2 other ones for things like pain or anxiety associated with pain or depression due to pain. So there are some cross benefits here for sure. Um, what are some of the demographic changes, and trends among older adults that use cannabis? This was a huge study. They looked at 47,000 people. They looked at a little younger age range, 50 equal to 50 or older. But the increases are kind of crazy to think about. 57% increase in the year prior cannabis use, from 2006 to 2013. 250% relative increase in last year cannabis use in those aged greater than or equal to 65 during that time frame as well. I mean, that's a huge increase. So there's a lot of people using it, especially older adults compared to what then they used to. So cannabis and trends in older adults. Um, this was a really good study. This came out actually in the Journal of American Geriatrics study and the Journal of American Geriatric Society and cannabis and emerging treatment for common symptoms in older adults. And it really looked at um, trends as well. And it just showed that they are using it more for sure. 15% reported using cannabis within the last 3 years. Um, and actually, in this study, majority were female. And actually, higher education levels as well, which I kind of find interesting. But that was just it was about 568 people, but it does show a little bit of insight there. And if they were using it, more than half the people in the study reported daily or weekly use. So they were using it fairly regularly. That's the other thing to keep in mind. What were they using it for also in the study? A lot was pain and arthritis. That was the number one reason for sure. I find it interesting when you think about some of these things because, when you think about pain and what we use for pain in older adults, everything we use has some negatives to it, right? So when you think of things like just general arthritis, which can be pretty debilitating, and cause a lot of issues, especially in people in their 80s and 90s. Think of spinal stenosis and other things like that. Uh, our options are okay. Tylenol is great, but sometimes you need more than Tylenol. And each one of these, as we escalate them, whether it's anti-inflammatories, things like ibuprofen, can also have negative side effects on kidneys and other things and bleeding risk. So there's not a great one size fits all for older adults when it comes to pain control and especially arthritis type pain. So it's something to consider. I think I'm not saying we choose it for everyone, just arthritis pain, but for certain patients, it might actually be safer or more beneficial than even anti-inflammatories like ibuprofen. Excuse me. Um, so this is another article about its use in chronic pain. And actually, this is a review of multiple different studies that came out, and actually greater than 13,000 participants. And it actually looked at this is a really interesting study. It looked at like what was the best formulations to treat pain, side effect profile of different doses. So they found that oral synthetic products with higher THC to CBD ratios had some improvement in chronic pain. There is some data that definitely supports that in its use. The problem is at higher ratios, kind of what I recommended before, if you have a much higher ratio in terms of more THC than CBD, it increases your risk of side effects, things like dizziness, fatigue, sedation, maybe a little bit of confusion. So there's definitely a fine balance there, which is why you start at a ratio that's definitely way more CBD than THC, and then you slowly increase it if you have to at very, very small increments. And then also you have them maybe take it at night, prevent the risk of side effects, see how they tolerate it. So can improve chronic pain, which is good. And maybe some benefit there. But again, have to be careful with how you use it. So the $1 million question. I probably have some about, let's see, 10 more slides. So I'm just going to try to leave about 10 minutes for questions. Um, Not quite. Does it work? Right. I think that's a really honest question. And because there's significant increases in consumption, older adults are using it. Um, there's been a lot of study. There's more studies recently. I was just saying in the last 10 to 20 years, which is helpful. The results were somewhat mixed though in terms of the benefits and risk. It's really kind of depends on the. I mean, it's going to sound kind of cliche, but it depends on the patient. Every patient's different how they respond to it. What they also found with the studies were often small and inconsistent results. So it's not like all of them were these huge studies. Some of them had 80 patients, 100 patients. So it's really hard to sometimes make large population-based decisions about its use, especially for pain, and other things, if these are all small studies. Um, Cannabis use was associated with increased risk of side effects. Another concerning one in this study was accidents and cognitive impairment. And this is a relatively newer study, came out in 2023. But this one did show benefit in dementia, Parkinson's disease, and cancer-associated pain. But again, inconsistent depending on the study. So it really is an unclear benefit to risk ratio still, which is where I think it comes right down. Depends on the patient and what they need help with, what they've tried, what hasn't worked. Would I make it my first line? No. But would I have it in my toolbox? I think I would. And it just would depend on the patient. Another good question is, does it hurt? I know it's kind of simplistic, but these are I think the basic things that my patients want to know. Recent studies have shown is a well-known impact that I mean, this is not surprising, right? Can slow processing speeds, decrease attention, and decrease executive function. One review of 184 older adults showed 80% reported some benefit, but 33% reported adverse effects such as dizziness, lightheadedness. What about driving? You have older adults that are still getting behind the wheel, which is fine, but some of them are maybe have a little bit of cognitive impairment, and you add a little bit of this on top of it, it can be concerning. So I think you have to be aware of that as their provider or their care team, and be sure that you're discussing and asking some of these questions if they are on medical marijuana. I mean, I'd say the same thing about opioids. I mean, it still applies for that as well. And we still prescribe that. So, it's interesting, I think, but you still have to be careful and ask them these questions. Oh. So, again, does it hurt? Another study in JAGS was recently done and examined cannabis use in ED visits. This is an interesting one. I don't really know how to interpret it, but cannabis was related to ED visit rate that was increased for older adults age 65 and older from 2005 to 2019. So their question after this was, could actually this be an adverse effect in itself? And actually, does its use increase ED utilization or ED visits, for a variety of issues for older adults? Possible, not sure. Again, I think more studies need to be done to really show that. I think it just shows that side effects can happen in older adults, and again, it requires active management. And also, I think it's important to have multiple members of the care team that are following along with someone who's on medical marijuana. I think it's helpful, whether it's social work or nursing, to have a lot of inputs from other people. How are they reacting to the med? So the prescriber knows exactly what's happening. And this is just some new data again about how older adults are using this. This is just within the last couple of years. Again, people are using it for severe chronic pain. It's happening. That's what they're using it for, majority wise. And when I say using it for cancer, that's really about cancer related pain. However, in what people are tending to using it is that lower THC to CBD ratio. So it's more compared to younger patients. So that's a little bit interesting in the sense of how they're using it. And they prefer the liquid formulation, which, kind of makes sense, maybe especially as people get older a little bit. But that's actually just how they're using it for this study, what they found. So Canada knows, right? This is actually a really cool resource. The reason why I'm including this is because I think they did a really good job actually providing this to their population of older adults. And they actually are recognizing this already as a trend. It was produced by the government of Canada regarding health effects of cannabis in older adults, 55 and older. And it's really how to minimize your risks, health effects, and benefits, common interactions with other substances, etc. I think it was about 15 or 20 pages, but it's really well done. I actually encourage folks to check it out. I have the link at the end of the presentation. It gets into its use about pain and other things, but it gets into risks. It really goes through everything. So it's really good. The other thing is cost of medical marijuana. It could also be pretty expensive at times. This has changed, I think, a little bit. Um, and the problem is when it's illegal federally, it's covered by how is it covered by insurance companies, right? And that gets a little dicey. And this is where it gets a little weird. I think some people still will get it from other sources which aren't safe. I mean, this is a concern. Whether it's on the street or from someone else that's not reliable and you don't know what's in it, right? And of course, with some of the concerns with it being laced with fentanyl and other things, you have to be careful of that. So I always encourage my patients to using it to get it from reputable sources like a dispensary, and from a prescriber that's prescribing a certain ratio, or else it's going to be very unclear what you're getting, and that's not good. I'm not going to go through this. This is just what it's for in your state and how you go about it to prescribe it. You must be registered with the Department of Health and take a course as well to say that you're okay and be listed as a prescriber on their website in New York State that you could prescribe it. So just something to know. And also the patient needs to register with the Department of Health. And, this is where actually a nursing home or assisted living facility can actually be a caregiver for the patient. It's a little sticky, but it can be done, and there's a form to do that. And it's actually a part of the public health law that they're allowed to do that. Again, it needs to be regulated closely. You need to do it a very certain way. Obviously, diversion's a risk and other things, but there is an avenue to do that for a facility to actually take that role for a patient that's living at their facility. So they can actually be a designated caregiver. That could be obviously a family member or someone else, but they actually include employees of facilities, um, as long as it's acting within their scope. Obviously, if they abuse that privilege, there's repercussions for that for sure. So one more thing that considers a medical marijuana policy, this is just more for the nursing home or assisted livings. I think again, it's doable. I hope it's actually going to become more doable in the future for patients that are wanted or it's indicated for. But it's really right now, you still have to be very careful about how you use it and who is responsible for storing it, who's administering it, who's obtaining it. This all needs to be outlined. Again, what I just mentioned is the facility a designated caregiver. What does that mean? Method of tracking it. How, if the facility is a designated caregiver and can get it, how are you tracking that? How are you making sure it's getting to the patient? Um, you may want to even reserve it for patients who can self-medicate or they have responsible designated caregivers that can do it. So it's really the patient owning the risk and they store it. It's really all on the patient. It's just good for the providers to know, obviously, that they're on it, but it's really up to them. So you can do it in that way too. And obviously, you have to outline what qualified conditions are appropriate in the policy. So in summary, use of medical marijuana continues to grow in older adults for a variety of conditions, but especially pain. I honestly think that there's still an ongoing role, even if these other conditions kind of go to the wayside. I still think that there's enough anti-inflammatory effect, especially when you have really high CBD ratios with low amounts of THC in older adults. They're not really going to get those psychoactive benefits and actually might get a little anti-inflammatory and pain control. I think there's definitely potential value there. Still trying to figure out that benefit versus side effect ratio. It's going to be different for every patient. Still have to use your kind of clinical judgment and things through that. Research is ongoing and more to come. So very excited. We'll be seeing what happens with that, and it's not going away. At this point, it's going to be a part of our culture, our society, our healthcare industry. So I think it's really important, whether it's for pain or other conditions, that we really understand it, know what it is. You don't have to be an expert, but still we understand what it is and some of the benefits and risks for our older adults. And then I just have some resources with some of the stuff at state level. And then Leading Age has some great things as well. And then that document I showed that Canada made is really good. Questions? Thank you.
Yes, thank you so much, Tim. So, our first question, if you could go back to the cost slide,
Oh, sure.
you had mentioned some scenarios on that. Denise wondered, what do the scenarios represent? That was
Sure.
kind of way back in the beginning.
So in the beginning, not the recent one I talked about cost.
No,
All right. Let's
there was like
see.
a bar graph.
Yes. Yes, 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 yes. Yes, there's 2 separate lines. Sorry, I didn't go through that well enough. Now I know what I was talking about. So, the, um, scenario A, and they're very similar. One of them is just a wide range. I'm sorry, I can't go back to the slide. It would take me forever on this my separate monitor, so I apologize. But there was a black line and a green line in the bar graph, and the black line was sometimes more than the green. And really, what that is representing is the wide range of if how many states it was legalized in. So the higher projection of like in 2030 of 71 billion means that was like if all states legalized it by 2030. But if it kind of stays the same, $58 billion would be the sales if there weren't as many states legalized. So it's like a range. So that's what that meant. Sorry, I didn't explain that.
That's okay. Thanks so much. And I will email out a copy of the slides after the session today. So our next question is from Kimberly. She says, is medical marijuana considered a medication-assisted treatment for patients with substance use disorder? And for an example, is it an alternative to methadone?
Mhm. So it's not a treatment in the sense of like in terms of an alternative to methadone for substance use disorders or buprenorphine. No, it's not on that level where you can kind of treat it in the sense to decrease cravings to a point where um, to wean them off of it. So it's definitely not doesn't have that kind of property. But where the benefit is that if you have someone that's just using it for pain, and there is some concern that they might be at risk for addiction in the future, or you just want to actually decrease their opioid use for other reasons, things like constipation, other side effects, medical marijuana could be used to maybe decrease those doses, but still give them some of that similar pain benefits, if that makes sense. So yeah, you can't use it as a assisted treatment for opioid use disorder. It's really just to kind of wean people off if they're using it for pain and decrease that opioid burden some. Yeah, it's a good question.
Okay, thanks so much. We have one more. Are you able to speak about the effects of medical marijuana on blood pressure?
Hmm. And so sort of. There is some data that actually shows. I mean, and maybe this is a little bit pain control, right? I do think sometimes if people are in chronic pain, in a constant state of pain, their bodies are going to be a little more, I'll say, ramped up. Whether that's because just the way that their bodies are acting, and that could increase blood pressure risk. So, as a secondary benefit, if you're controlling pain more, could that lower that risk of blood pressure and other things? Sure. Um, to that point, though, it actually reminded me of something. There was also some research actually recently that was coming up. I talk about some of the does it hurt scenarios. There's actually been some data that's come out as well that shows that it can increase some folks' risk of cardiovascular issues. So whether that's blood pressure or actually cardiac related things like coronary artery disease, there is some data that it could actually potentially do that as well. I think that study, I have to look back. I don't think that was done in older adults. I think that was done in younger patients. And it was just one study. I don't think it was very big. I know that got a little bit of press though. So there is a little bit of still trying to figure out on the cardiovascular side, what are some of the benefits and risks of medical marijuana? Yeah, good question.
Okay, I also had a question, and this could be
Sure.
from either your experience or from the literature, but is there any stigma among the long-term care staff when someone is prescribed medical marijuana? And then how do you address that with residents? How do you address that with family members or whomever?
Mhm. Yeah, I don't know if there's so yes, there used to be for sure more stigma, I think. I think in the last 5 years that stigma's gone down a fair amount. In post-acute care facilities, whether it was with staff or the residents or the families. Um, I do think though you need a lot of education for the staff. And the problem is, remember, if you're using it, there is such a kind of policy that you have to follow and protocol you have to follow. So that needs a lot of education on the staff side and the resident side to make sure that they know what they can or can't do, how it works, and what the facility's role in that is. So I don't think there's a stigma per se, as much as there used to be. And again, remember, it's not like in your face. Like I think sometimes, like it would be really hard to smoke marijuana, in a facility, especially there no smoking and other things. So it's more just really done by tinctures and edibles, which is not in people's face as much. Like you may never know
Mhm.
someone's even using it, right? So as opposed to if someone's out in the milieu and they smoke it, right? That would
Right.
be a little different. So yeah, less of a stigma, but a lot of work to do and education to do across the whole board. And I would recommend,
Mhm.
obviously, you definitely involve your facility leadership, like the administrator, but also the medical director for sure has to be involved in this, and helping standardize it and make sure it's done the right way.
Okay. Thank you so much. So I don't see any more questions, and people are usually not opposed to us ending a little bit early. So I want to say thank you so much to our subject matter expert today, Dr. Tim Holahan. We appreciate you taking the time to talk with us about this important topic. And then we hope to see everyone next month on Tuesday, May 21st, when we will be joined by Savannah Jean and Benjamin Nguyen to talk about care considerations for Native communities. So thank you again, Tim, and everyone have a wonderful rest of your day, and we'll see you next month.
Bye bye.